Back in 2013, the Chicago Bulls lost their starting guard to a knee injury that resulted in a medial meniscus tear. Meniscal injuries are a common diagnosis for knee pain associated with sudden changes in direction with the foot being fixed on the ground, which can be seen in cutting and pivoting. Hyperflexion and high-impact compression loads can also lead to injury. Before we get into more detail on meniscal injury and the different paths to recovery, let's touch base on what the meniscus is. The menisci are fibrocartilaginous crescents found on the surface of the tibia of the knees. They act to reduce friction and provide extra support during functioning. The menisci help to dissipate the weight and the force of the body on the knee to reduce stress that is put onto the bones of the knee. In each knee, there is a medial and lateral meniscus in the joint between the femur and tibia. It is important to realize that the outer rim is more vascularized than the inner, which plays a role in the prognosis and treatment of tears to the meniscus. The outer rim has a better chance of healing and therefore is approached more conservatively. It has been noted that trying to save and preserve as much of the meniscus after injury shows long-term benefits which will help dictate surgical interventions. Meniscal tears can occur from acute, traumatic injuries like that of Derrick Rose, but can also be seen in an older population from chronic degeneration with mild arthritis. If a tear is present, there will be a handful of signs and symptoms to look for. Indications that there might be a tear are pain that worsens with movement and gets better with rest, locking or inability to flex or extend the knee, popping or giving away, tenderness to the knee joint, and swelling within 24 hours of the injury. When seeking the advice of a healthcare provider, there are several ways of diagnosing the presence of a meniscal injury. While imaging and MRI is the gold standard for diagnosing a tear, there are clinical presentations that physical therapists use to rule in or rule out the possibility of a tear. Indicators that a physical therapist would look for are joint line tenderness, effusion, quadriceps inhibition and atrophy over the first week following injury, and the use of positive entrapment tests. These tests are seen here and are named the McMurray's test, Apley's compression and distraction test, Thessaly's test, Egge's test, and the pivot shift test. Detecting a tear is the first step, but there are different types of tears that will lead to different interventions. Location and severity will determine if surgical or non-surgical means of treatment will be utilized. At first, conservative approaches may help to improve pain. These interventions consist of temporary changes in activity to avoid aggravating the tear, NSAIDs to control swelling, and physical therapy to help quad strength, edema reduction, and neuromuscular control. If pain persists, surgery might be the better option depending on the patient and their goals. Partial meniscectomies and complete meniscectomies are options that remove part or the whole meniscus. Meniscal transplants from a donor can be used in some cases instead of a complete meniscectomy, but have some shortcomings. There needs to be good ligamentous structures to begin with, the rehab is longer, and some surgeons will even recommend never running again on a transplanted meniscus. With more of a focus of late being on preserving as much of the meniscus as possible after injury, there is an option of meniscal repair if the tear is in the outer rim of the meniscus and in the vascular zone. Indications for a meniscal repair are traumatic lesion within the vascular zone, intact peripheral circumferential fiber, and minimal damage to the meniscus body, and the tear being longer than 8 millimeters. The repair might be done using sutures or arrows that are shot into the meniscus and bioabsorbable. Meniscal repair of the vascular central region has been on the rise, though, due to the importance of preserving the meniscus, with modifications to the surgical techniques by utilizing a fibrin clot, rasping of synovial fringe, and creating vascular access channels to increase the likelihood of healing. Upon repair, there are 4 phases of the physical therapy rehab plan. The main focus is to strengthen the hip and knee musculature and obtaining full range of motion with a focus on not disrupting the repaired meniscus and not aggravating the tissue healing process. Here are a few exercises that are commonly incorporated at different phases of the recovery process. The focus of the phases are to control pain, establish range of motion, prevent muscular atrophy, and progressive strengthening and functional activities to get the patient back on track. A meniscal repair rehab plan can take up to 6 months to be strong enough to return to a sport.
The distance fits in perfectly, Mark.
There's Rose. Oh, he's back. Got got a little bit of bounce in those legs still, folks.
Here's a list of useful articles and resources to give a more detailed account of all the implications involved in meniscal injuries and the different options out there for treatments. These references will help give a more in-depth picture of the different topics that were touched upon in this video.